You've been involved in teaching the doctor-patient relationship. That is key to the patient having trust in the physician and also being able to accept what the physician feels is best treatment. Can you just expand on what you're working with that?
Well, let's think about these conditions. Someone goes to the doctor and they say, I have this pain, and the doctor does a medical evaluation. They do some studies, and what do they say? We can't find anything. There's nothing wrong. Learn to relax. It must be stress. How does the patient feel? Well, the patient feels somewhat delegitimized. They feel they don't really understand, and they'll say to themselves, well, I just need to go to another doctor till they find something, which won't happen because there won't be a structural abnormality, or they'll say, maybe I'm crazy. Very bad situation. But if the doctor says, I understand you have a real medical condition, here are the criteria for it, even though the studies are negative, that means we're not finding structural abnormalities, but you have a disorder of gut-brain interaction that's producing real legitimate pain. By providing that validation and that education, the patient can accept it. And then you can use other methods of communication, such as, we need to work together on this. You've had this for 20 years. I understand it's been a challenge for you, but if we can get you 25 or 30% better in a few months with treatment, would you be satisfied? Now the patient is not only feeling validated, but they're given a sense of hope. And in addition to that, it becomes a collaborative. This is, the Institute of Medicine in 2001 talked about crossing the chasm between patient and doctor, because in the traditional way is the doctor's up here, the patient's down here, very hierarchical. Here we need to get the patient involved in management. So if we start to make recommendations where the patient makes choices, here's treatment A, it has this effect and this side effect. Here's treatment B, this effect, which would you prefer? Now the patient is not only engaged, but they're participating. And most of the clinical outcome research shows that improvement, positive clinical outcome is based on the patient's sense of responsibility for their self-care. If they keep going to the doctor and rely on the doctor, there's a problem in two ways. One, the patient feels powerless. And second, the doctor feels intruded upon. They keep coming back, and I can't find the right answer. But if you work collaboratively, then you're sharing the responsibility.
Yeah.
That's communication.
Yeah, I have had experience where I have sent patients to a physician, and they have come back to me saying, the physician says, I can't find anything wrong with you. Does it mean I'm imagining all this, doctor? Now, I think there is an educational matter that people and doctors have to be trained to realise that just because you can't see anything doesn't mean that there is no problem there.
Western society, and I say Western because we don't see it to the same degree in Eastern cultures, is caught in a concept of what's called biomedical reductionism or dualism. It's either medical or psychiatric, mind or body. And that's what has led to this problem. I think the history of this is very interesting. The whole idea of this mind-body dualism really goes back to the 1700s, 1600s. René Descartes.
Yeah.
He basically at that time, and the reason why it relates to medicine is that at that time, the human body couldn't be dissected. And the reason why it couldn't be dissected is the spirit was thought to reside in the human body. Here comes Descartes. He says that the mind and the spirit is separate from the body. The body is machine-like. The mind and spirit are separate. What that led to was human dissection. Human dissection led to the understanding of ulcers and cancer and morphologic abnormalities. Now that then led to us understanding medicine in terms of morphology. X-rays, histopathology, nuclear imaging is all based on what you see. That's very different from what the patient experiences. And at the time, the reason why the stigma occurred is that if someone had abnormalities of behavior or symptoms that weren't visible, at that time it was considered a spiritual problem, possession. and they went to the asylums.
Yeah.
And the asylums were places where you couldn't study. In fact, it wasn't until the beginning of the 20th century when mental illness was put in the medical curriculum, because it was considered not amenable to the same study. So as a result, the stigma has stayed that if you don't find something morphologically, then you have something psychiatric or not real.
Yeah.
Nowadays, because of our understanding of brain-gut communication, altered microflora, visceral hypersensitivity, all of that, it leads to a different understanding disorders of GI function. And that's what we're trying to do, is to promote a very different understanding from this dualistic concept.